we have a wonderful panel of speakers, Dean Chang-Chuan Chan, who will speak about Taiwan's success story in controlling the pandemic. A few weeks ago, they declared proudly 0 cases. This will be followed by my dear colleague and friend, lifelong friend, Dr. Wafa Al-Sadr, who is an expert in a way that no one else, and will be talking about how to use the existing infrastructure in Africa to combat the pandemic. And then finally, we're really honored that Dr. Rakesh Kumar from India will be sharing India's experience in containing the virus. And then finally, our own Senior Associate Dean, Dr. Ashish Joshi, will be talking about a global approach towards data and data monitoring. Our first speaker today is Dr. Chan, and thank you for being up at close to 2:30 a.m. in Taipei. This is a true testimony of your friendship to me, Dean Chan, and I thank you for that. Dean Chan is the Dean of the College of Public Health at the National Taiwan University. He is also the Joint Appointed Investigator for the Division of Environmental Health and Occupational Medicine at the National Health Research Institute in Taiwan. He has published internationally on topics related to the environment, health and risk assessment, environmental management, and global health. Dr. Chan, we're really very, very glad to have you with us today, and you will set us on a wonderful goal of perhaps the world one day declaring what Taiwan has declared already weeks ago of 0 cases. This has been achieved because of the incredible population health infrastructure that Taiwan has established, and we would like you to educate us about the Taiwan experience in the next 20 minutes.
Yeah, it's my pleasure to be with you to share some of the experience we have so far to control COVID-19 in Taiwan. Many people ask me what's the reasons why we are doing a kind of successful control we have so far, but we are still have reservations because this is a new disease and new virus. We still have a lot to learn. So today, I just want to share with you what procedures we have taken in the past 4 months to deal with this difficult problems, global health pandemic in Taiwan. I think the first things I can share with you is the lessons we learned from the past pandemic. And you know, in 2003, we had the SARS, and that hit us very hard, especially we saw doctors and nurses die in hospitals. And the whole society was shocked, you know, because hospitals supposedly to be the places to cure people and taking care of the sick people. But doctors and nurses were dying, and one hospital was closed because of infections. So after that, we have made decisions, the whole society, we have to invest more in public health infrastructures. So over the past 17 years, we have been preparing that we should be ready for futures newly emerging diseases, and hospitals has to be ready for a lot of infectious control in the meantime, in the normal time, and during the pandemic, a lot of hospital has to be converted to be ready for that. And just give you examples, all of our hospital can be readily converted to have like fever screening that you can check fevers and in front of hospital clinics. not to let patients come into your hospital, then the hospital can be reorganized to make rooms for hosting these patients. So in this time, this COVID-19, potentially COVID-19 patients to isolated wards or ICU or negative pressures rooms. So in some of the hospitals, they will evacuate the whole floor and rearranges the entrance and the exits of this movement of patients and healthcare workers. That's been implemented in all the hospitals in Taiwan. The other one is from the SARS lessons is we cannot expect timely and correct information of new outbreak from China. And in SARS outbreak, we has a couple months delay. We didn't know that some of disease has been in Taiwan. So this time we are very cautious. So way back in December, we have some information that there could be something outbreak there. So until December 31st, even though there's not confirmation of outbreak in Wuhan, and we went through different channels to check, and I'm one of them that the government asked me to help them to identify and verify some of the reports we received from our informal channels, and say this could be a new things to happen. So after just 1 day, we made a decision. This should be a real one, and we better to be cautious. So from then on, we went aboard of airplanes from Wuhan to check fevers. Then later on, we banned the train, the travel from Wuhan, and later on, we expand the bans to all the travelers from China. So border control, when there is a potential outbreak and origins of the outbreak, even though you cannot confirm, but you have to act fast. So the border control, depending on the information we can gather at the time and act quickly, and this is one of the best way you can fend off imported cases from potential hot zones. And if you check it back, most countries did not do that in January, but we act on this the whole month in January to enforce a lot of border controls policies we have. And that's let us buy a lot of time to start planning mitigation procedure or even stronger containment strategies. And after that, we apply the technology we have so far compared to 17 years ago. What do we have? We have a lot of good information technology we can use. So we know we cannot contain totally. There are always a leakage of cases coming into Taiwan from different sources or from the cases that cannot be identified by fevers. And because we didn't know it would be like SARS or not. And later on, we know this COVID-19 is very different from SARS. So we apply a very, comprehensive digital tracings and to find a case, isolate the case, isolate the contact persons to the confirmed case, and enforce a very strict home quarantine or home isolations of confirmed cases. And people under investigations. So this strategy work. It's 14 days stay home policy for all these possible cases. And once people are confirmed by RT-PCR's test, and they will be moved to the hospital for 14 days and under the separations care. So this way we contain the spread of the disease in our communities. So the second strategy, which is very useful for us, is this finding, searching, isolations, etc., supported by information technology that we have so far. Just to give you one example, so they in the middle of January, we find out it's very good if we can combine the immigration data, which has a travel histories to China, with our health insurance data. Then when people come back from China, mostly Taiwanese businessmen, and if they got some kind of diseases like fever, coughing, and if they go to any clinic in Taiwan, and the physicians will, from this national health insurance card, has information of the travel history. So that make us more precise in doing these contact tracings, and the clinicians who are taking care of the patients will be in high alert, and they will recommend this person to a hospital. So this information technology is important, and why we can do that, because we have single care system. There's a health insurance system, and all the medications are in the IC chips we have. So when you're in the pandemic, if you can invoke these systems and put in the public health measures in this information system, then it's very powerful. It took almost 24 hours for our IT persons to add on a kind of application in these systems, then make it work. So information technology is very important. And another big issues in Taiwan in the beginning is wearing masks. During the SARS outbreak, and because of our customs, cultures, and the way of life, and people try to have something to protect themselves. And wearing masks is a very important thing that time, and it became a panic buying, and was short of supply. So in the first week, I recommend to our government, be careful of supply of masks, especially surgical masks that all of the people would like to have. And I gave them estimations that the amount people need would be about 10 times. So when in the normal time that people buy one, and they will buy 10. And in the beginning, they were too confident that we have enough supply. But in 1 or 2 days, that's become far short. The supply is far short of the needs. So the government ramped up a supply to form a national teams that we have a supply of materials and manufacturing lines ready in 1 week. So they can start producing. Then we can produce some amount, but they are still not enough for the people's needs. So government again apply information technology to nationalize and rationalize the surgical mask buying policies. And the clever way is we mobilize the pharmacies in the whole countries. So such masks become medications, a prescribed drugs that people are allowed to buy 2 pieces per week. So you can see people line up in front of the pharmacy, just try to buy 2 pieces of mask. And it's so orderly. And this is the kind of things when you are in pandemic, and there's a lot of regulation instructions. And from my perspective, all of these measures are trying to make people become passive, because you have to obey this, you have to follow these rules. But the buying mask is an activity you make all of your citizens become actively engaged in some activities that could be useful. And I try to convince the public that from the beginning, there is no guidelines in WHO or US CDC. They always say that there's no need for wearing masks. But my views from the beginning is it's a way of protecting yourself and also protecting others, especially in a crowded society. If you are taking MRT in Taiwan, buses in Taiwan, it's very difficult to keep social distance, and wearing masks become a way that you can protect others, because you don't know whether you are a similar carriers or you are sick. You're sick, you always need to stay at home or wear a mask. But even though you are not sick, you have no high fevers, there's a way you can protect others. So later on, I coined that is a kind of a quasi vaccines that is a kind of physical barriers. And if all the people surrounding you are wearing a mask, and there could be a kind of herd immunity that you can keep this epidemic curve as low as you can. So mask awareness is a very important self protection measures during this pandemic. Not to mention about hand washings, that's the most important one. So hand washings movement has been promoted from the beginning. And we also build a very good infrastructures. It's so easy in Taiwan, in public. You can find the places you can wash your hands in buildings, in public transportations, buses, etc. Compared to Europe, it's very difficult to find places to wash your hands in many cities. But if you're coming to Taiwan, Korea, or Japan, there are also widespread places for you to wash your hands. So it's much easier to have this good personal hygiene practice in Taiwan, that is hand washings and wearing the mask. And so as the epidemic move on, and we have to start doing these social distancing policies. And I can recall the best policy we have is to delay the opening the schools. So once you don't know the pictures of the epidemic, the best way is you can cut down the mass gatherings you can. And schools apparently is very organized institutions that we can try to reduce the context of the students and teachers, students and parents, and by delaying openings. And it's a big decision, and it works. And by delaying the school opening, mainly from the universities, because our universities has also a lot of students from China, Hong Kong, and Macau. And at the time, it's all the epidemics are occurring there. So we trying to convince the students that they will stay back in your home for a while, and we will see what we can deal with controls. And for some of the students who are already on their way or just arrived in Taiwan, and our government asked each university to set quarantine dormitories for all of them. So our university would put over like 300 students from China and Hong Kong in a quarantine dormitory that we serving them meals, taking care of them, you know. And this way of social distancing works, yeah, because you confine everybody together and put them in one place, and once they are safe, they can be released. So this delay in opening is important, and not to mention the high schools, primary schools, kindergarten. By doing this, you know, you cut down a lot of possibility of person-to-person transmissions. Delaying school opening, not totally close. You know, if you act earlier, you don't need to close the school. So after that, we open our schools and ask every student has to wear a mask if you cannot keep 2-meter distance in the classrooms, and we cancel all the group like the activities in schools. And later on, all the university and Ministry of Education enforce this social distancing policy by cut down the big class from 100 to 60 per class, that you are mandatory to do this internet online teachings. Okay, so all these measures try to cut down the person-to-person transmission possibility. But if I look at a lot of countries are still closing the schools, I think that is a necessary measure to control this disease. But if you act earlier, you can. If you act earlier and you delay the opening, it will be a better policies. And so that you make a difficult situation when you in the beginning of the epic curve. You have to act. Once it's you're entering this exponential or beginning of this exponential growth, it's too late. So this is some of this we have. And for mass gathering, we also observe a lot of infections related to religious activities. And there's also a big religious activity in Taiwan that will attract millions people together. It's Taoism rituals, and we call this goddess Maju, and it's a parade for over almost 3 weeks. So we have a lot of collaborations and communication with the religious leaders, and finally they observe they have to delay or totally cancel this year. So I think we avoid a lot of potential outbreak occasions we have in Taiwan by doing all these non-pharmaceutical interventions strategy, while we have a very limited information on this. So all of this, you can see that in the beginning of the pandemic, we better err on precautions. You better to be criticized of overreacting earlier than you will regret later. So this is some of the lessons I can share with you. And the Taiwanese story is it's a cooperation between government, citizens, and academic, and we have a mutual trust, and the trust of the people on government's measures are high. So these kind of activity so far can be synchronized in our society, and there's very few disputes in our society in terms of this infectious disease, as I observe in some of the countries. And communication is also important. You have to be transparent, communications, and always, because we are in a democratic society. So we are very proud. We are so democratic, and we have free freedom of expressions, and the media is always criticizing, but still we can move things forwards. So Taiwan, as a democratic country, can serve as a kind of model. So even we have to enforce a very strict control measures and restricting people's freedoms sometimes, but it still works. So
Thank you, Dean Chan.
this is my my sharing with you so far. Okay.
It's a wonderful and unique experience. Obviously, the School of Public Health has played an important role in working with the government, especially that the Vice President of Taiwan was one of the professors in the School of Public Health. So I hope that we will all be in a similar position to exert direct influence on policies around the world. There may be some questions at the end, but I will move now to the next presentation. And let me introduce Dr. Wafa Al-Sadr, who is a university professor of epidemiology and medicine at Columbia University and the founder and director of ICAP at Columbia University, the director of the Global Health Initiative at the Mailman School of Public Health. She also holds the Matilda Krim Amphar Chair in Global Health at Columbia and is affiliated with the Harlem Center as an attending physician. Dr. Sadr is a prominent researcher and has led numerous epidemiological and clinical interventional global programs, and her experience in building infrastructure is unequaled in the areas of HIV, TB, and non-communicable diseases. And that's why we called upon her today to contribute some of her perspectives and personal experiences as to how the infrastructure that has been built already in Africa might assist in this next wave of the COVID epidemic as it could potentially spread in African countries. So welcome, Wafa, and we are very eager to listen to you.
And thank you very much for the opportunity. And I'm going to share my screen. Can you see the screen?
Yes, excellent. Thank you.
Okay, great. So thank you very much for the opportunity to present today. And I'm going to talk about COVID-19 in Africa, the status of the pandemic, as well as the response to date. I want to first start by thanking the sharing of the experience from Taiwan, because I think there's some very, very important lessons learned for all of us that we should heed as we're moving ahead in confronting this pandemic. So here's a brief outline of my talk. I'm going to just give a very brief global snapshot in epidemiology and where we're at today globally. Then I'm going to pivot and talk about COVID-19 in Africa, touch on the Africa's response thus far to COVID-19. I'll talk about the impact and potential impact of COVID-19 on other health priorities in countries in Africa in particular, how we can build on the existing infrastructure, and end with a few conclusions. So many of you are aware, of course, of the global status now, and this map is very familiar to many of you, I'm sure. As of yesterday, there were more than 3.2 million confirmed cases of COVID-19 globally. And I want to stress first that whenever I use the term confirmed cases, this means that these are only the cases that had been tested had a PCR positive for the SARS-CoV-2 virus. It's estimated that probably in all likelihood, the total numbers of COVID-19 cases is between 10 to 15 times, if not more, higher than this than the number of confirmed cases. And in total, there have been now globally more than 230,000 deaths. By region, 46% of the confirmed cases have been reported from Europe, 40% from the Americas, And then lower percentages, as you can see on the slide, 6% from the Eastern Mediterranean, 5% Western Pacific, 2% in Southeast Asia, and 1% from Africa. The top 5 countries in terms of the largest numbers of reported cases, the US leads the way, followed by Spain, Italy, United Kingdom, and France. So the evolution of the pandemic is interesting and important to keep an eye on. If you can see here in this figure that if we go back to the late December 2019 and January of 2020, the cases were first reported, of course, from China here in orange. And then as we move forward, the cases in China stabilized, and in that region, actually this is Western Pacific region overall, not just China, they stabilized and are now a very small proportion of global cases here in orange. As you can see, what happened though by the beginning of March is an astronomical rise in numbers of cases in pink here in Europe, and then in yellow in the Americas, far exceeding the numbers of cases from Western Pacific region. If you look, and then in purple are the numbers of cases in the Eastern Mediterranean. If you look at the bottom in this in Africa is in the blue, so you can see it still remains a very small proportion, as I mentioned to you, 1% of cases globally. In terms of the US, currently more than 1 million confirmed cases and more than 61,000 reported deaths. And of course, we know that New York City, where we're at now, where CUNY is situated and where I'm situated, is bearing the brunt of this epidemic, both in terms of the US epidemic as well as the global pandemic. Now, what about Africa, COVID-19 Africa? What we know are, again, based on confirmed numbers of confirmed cases, and there are lots of limitations to, of course, this number, because of it's totally dependent on, of course, the availability of testing for this virus, as well as the availability of strong surveillance systems to be able to identify cases, whether they be based on testing or based on a clinical diagnosis. Almost 1,600 deaths have been reported, and 53 of 54 African countries have reported cases thus far. And you can see in the bottom left on your screen the increase in the numbers of confirmed cases in Africa over time, cumulative number over time. Now, the map on your upper right-hand corner shows in the size of these circles indicate the size of the epidemic in the country, in the specific country. And overall, in the figure on your lower right-hand corner, the majority of cases in Africa have been reported from North Africa, followed by West Africa, Southern Africa, Eastern Africa, and then Central Africa. And at present, Egypt is leading in terms of the numbers of cases in Africa, followed very closely by South Africa. And then you can see here North Africa, Algeria, Morocco, Tunisia. And there's particular concern about what's the impact of the epidemic on Western African countries. And if you look by continent, again, in North America, obviously the US is leading in terms of the total, in terms of the numbers of cases. In Asia, now Turkey has surpassed all of the other countries, Asian countries, in terms of cumulative numbers of cases. And in Europe, we see a clustering of UK, Italy, Spain, and also Russia now is increasingly reporting larger numbers of cases. And as I mentioned before, this is African continent with Egypt, South Africa, Algeria, Morocco, and West African countries. Now, very quickly, what should be done when we face an epidemic or an outbreak or a pandemic? So at the top of the slide, you'll see the epidemic phases, and at the bottom of the slide in the lighter blue are the response interventions. And of course, we need to always keep in mind that the response should really be reflecting where we're at in terms of the epidemic cases displayed here in the darker blue. So of course, it's very important to have anticipation. We need to be prepared. Very critical piece of response is actually preparedness for outbreaks and epidemics, and to have early detection, rapid identification of a new pathogen or a new outbreak. And that requires, of course, they're having vigilant clinicians who can identify clusters of cases, as well as having strong sentinel surveillance and surveillance systems. Once we move to localized transmission, where you have cases that are transmitting to their contacts, as in the case of COVID-19, that's when containment should be mobilized. And by containment, we usually mean preventive messages, as was described in the prior talk, with hand washing and hygiene and hand sanitizing and so on and so forth, staying home when one is sick, and other kinds of recommendations. But very importantly, in the containment centers on rapid case detection with isolation of cases, as well as tracing of all contacts, and enabling these contacts to remain in quarantine for the indicated duration of time. However, what happens then is if containment and the public health response is unable to contain this outbreak or this epidemic through these activities, and is rapidly overwhelmed for a variety of different reasons, either because the rapidity of transmission of the virus, or the fragility of the public health response and the paucity of public health investments, then we go to amplification, meaning rapid transmission, sustained community transmission. And once this occurs, then we move to the phase of control and mitigation, which is centered on interventions like, for example, physical distancing, restrictions on gatherings, closing of schools, restrictions on travel, and so on and so forth. Hopefully, through these mitigation efforts, we can decrease the numbers of the transmissions that are being reported, and then can move into suppression, bringing back some of the containment tools that we have on our fingertips by re-energizing case finding and contact investigation. And then ultimately, if this is successful, we can ultimately hope for either elimination or eradication of the pathogen. So what has Africa done in response to building on these principles, but what has it done in response to COVID-19? I think it's important to first of all acknowledge that actually response in Africa has been quite vigorous, and really is really terrific to see how the continent as a whole, as well as the countries, have mobilized to do whatever they can to hopefully prevent what has happened in countries like European countries and in the US, and some also South American countries. You can see here first there was an Africa joint strategy for COVID-19 that was developed by the Africa CDC that has very important elements of ensuring coordination, so there's synergy, minimizing duplication, as well as the support for evidence-based public health practice intervention. And this is really, really critical to be evidence-based in confronting epidemics. There was a mobilization and training of healthcare workers, as well as the establishment, very importantly, of 44 laboratory representatives in all of in over 40 countries, and doing multiple workshops to train such individuals on issues around laboratory, but also infection prevention and control, IPC. Building of laboratory capacity is very important, and the Africa CDC took leadership role in this by enabling capacitating several countries to establish such laboratories, and also distributing diagnostic test kits, although there's a need for many more test kits in many of the countries where we work, at ICAP, for example. And then, of course, mass media public messaging, which is very important. In every stage, from the moment you identify a pathogen, you identify an outbreak, throughout the whole response, most importantly is communication, 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 frequent communication, and particularly communication by trusted members of the society, respected individuals, and having a consistent messaging is very, very critical. Now, the African countries were very much influenced by what happened in China, particularly what happened in Wuhan, China, and this shows here what happened, of course, with the intensive spread and amplification of the cases early on, with mass migration without strong interventions, and that then was followed by these very strong mitigation measures, including quarantines, suspension of traffic and travel, home quarantines, many other very strong mitigation measures, and these resulted in control of the epidemic. And I think that motivated many African countries to move very quickly, rather than to go through, I believe, rather than to go through that's first the containment phase and then see how that works, and then think about the mitigation, going into mitigation. Most African countries have actually moved into a hybrid response, but largely actually focusing on more of mitigation measures. So for example, on this slide, you'll see at the top the physical distancing measures that were implemented by, and in the circles here are the numbers of countries that have implemented them. Closing of, almost all countries have closed educational institutions, limited public gatherings, and then fewer but substantial numbers, limits on prison and hospital visits, mass screening and testing, and then again, supporting public use of face coverings. In addition to physical distancing, there were also strong measures on movement restrictions. And this includes nighttime curfews, which have been put in several countries, partial lockdowns, national lockdowns in other countries. So what you see is that many of the African countries really took a very vigorous and aggressive measures, largely focusing on mitigation measures through physical distancing and movement restrictions. So I'll give you two examples of the response in African countries, which I thought might be of interest. They differ, and might be that also makes them quite interesting. So first, the COVID-19 response in South Africa, again, centered on mitigation measures by national lockdown, closing all the borders, confining everybody except those who perform essential services. In addition to launching a COVID-19 alert system, they deployed mobile testing clinics in densely populated areas, particularly in areas where they had identified cases. And they employed large numbers of community health workers, which is very fundamental to their response, and to screen individuals, again, with symptom checklist. And as you can see, fortunately, based on the figure on your right-hand corner, bottom of your right hand of your screen, that there's been a decrease in the numbers of cases since the lockdown that was put in place. But again, it's always one has to be very careful with this virus, and we need to monitor this dip here for a longer period of time to be sure that this is not going to be followed by a surge in the numbers of cases. In Cote d'Ivoire in West Africa, where there's been alarming increase in the numbers of cases I mentioned before, the Ministry of Public Health has really mobilized and set up a referral center at the University Teaching Hospital in Abidjan, established priority facilities for IPC, installed quarantine sites in campuses and hotels, along the lines of what has been done, I believe, in Taiwan, for example, and other countries as well. And then increased laboratory capacity and remote training, particularly on infection prevention and control. And now they're putting in place voluntary screening sites and other interventions as well. So this gives you a sense of the vigorous response that has two examples of a vigorous response in the sub-Saharan Africa. Now we have been concerned, of course, about the threat of COVID-19 to the African continent, and we and others have written about this and tried to highlight this to the global community, and also to highlight the importance that the global community stand with Africa now to support it as it's facing this enormous challenge. So what are the challenges to confronting the pandemic in Africa? This is not going to be a surprise to many of you on this webinar. There are many vulnerabilities that are of concern, the fragility of the health system in particular. And that includes facilities, but also includes the workforce. The paucity of the workforce is also of great concern. Also the issues around the availability of laboratory systems and surveillance systems and many, many other elements of the health system that are quite fragile. Of course, there are other elements that are of concern, poverty, prevailing poverty, the dependence on informal community, and there have been reports, of course, on the impact on some of these mitigation measures like the physical distancing and the restrictions on gatherings and so on the poorest of the poor, who really depend on, for their daily food, on going to the market and being able to sell their wares, or having to go and work despite these quarantines and these lockdowns and so on. Access to education for children is a huge issue where children often don't have devices where they can receive virtual education. This has been an issue even in New York City, so you can imagine in many African countries. Issues around gender-based violence have been highlighted as well, and also concerns about violence by security forces who have been sent out to enforce some of these lockdowns in several countries. In several countries also, there may be mistrust of the government as well. And again, last but very importantly, the fear and stigma associated with COVID-19. So what are the impacts of, in a systematic way, the potential impacts of outbreaks and epidemics on the health system? Obviously, we start with there could be decrease in the supply of, and I'm going to go through these very quickly with examples. The decrease in supply of health services is very important. Also, a decrease in the demand for health service from the recipients of the care themselves, decrease in coverage and quality of services, and then could lead, all of these elements here could lead to worsening health outcomes for chronic conditions like HIV, for example, as well as for other conditions like vaccine preventable illnesses and maternal child health outcomes and so on. And all of these can lead to could lead to increase in all-cause mortality, furthering lack of trust in the health systems, and of course, long-term health system weakening. So a couple of examples, I think supply, the issue of supply of health services, and probably the most importantly is the issue of the workforce itself. And in this slide, you can see this is from Ebola, where the Ebola fighters were the person of the year for Time magazine. Is during the Ebola crisis, actually in West Africa, between almost 7% and 8% of health workers in Sierra Leone and Liberia died from Ebola. And that compares to 0.1 and 0.06% of the general population. So they were disproportionately affected and lost. And I think that's very critically to keep in mind, particularly when you have a very transmissible agent like the SARS-CoV-2 virus. So these are just examples of reports of the effect on healthcare workers. Again, COVID-19 hits healthcare workers and emergency response teams, and nurses and doctors are falling sick. And then again, this is of concern here is that coronavirus is killing more U.S. Health workers than official data suggests. And that's of concern. And that's kind of, I would not be surprised by this. Once hopefully this epidemic is behind us, that we'll see data similar to what was noted from the Ebola epidemic in West Africa. Health facilities are also been challenged as to who to treat and how to prioritize. And as you all know, there've been, of course, who to give the treatment to, and you have constraints and resources, whether it be intensive care units or ventilators, or many other resources at health facilities. And this is a challenge for us in resource-rich country like the United States. And you can imagine in situations where there may be countries sometimes have maybe 2 ventilators in the whole country. And then let's move then to the impact on health outcomes. These are data from Ebola and the epidemic, and that for example, what was shown then is that women and babies were dying, but not of Ebola. So because of issues around attention to Ebola, many of the maternal and newborn outcomes and newborn services were neglected, resulting in an increase in the death in both Sierra Leone and Guinea from non-Ebola related reasons. And of course, the decrease in demand, that's another outcome, is people start to fear the health facilities. And that's what's been noted actually already with COVID-19. And that was also witnessed in the Ebola epidemic as well. And this has been shown, for example, these reports from northern Italy, where there's a reduce in admissions for acute coronary syndrome. There shouldn't be a reason why these events would decrease in the population, but yet there was a decrease in hospital admissions, both for acute coronary syndrome and again for heart attacks. And the fear is that individuals actually are dying at home and they're not coming to the health facilities largely because of fear of getting the SARS-CoV-2 viral infections. Another impact has been on vaccination rates, and there are reports from several countries of a decrease in vaccination rates, which is of course very dangerous as parents and healthcare workers are, as parents are leery of going to doctor's offices or going to clinics and so on. And the WHO has actually warned that children will die as countries are halting vaccination efforts because of lockdowns, for example. This is ultimately another measure of the impact on outcomes is all-cause mortality. And there's beginning of actually evidence that the effect of the true toll of the coronavirus outbreak is not just going to be in terms of the COVID-related deaths, which we're counting every day and we're keeping a close tab on, but all these missing deaths, the people with heart attacks who are not coming to the health facility and dying, and many, many other conditions as well. So now I'll switch now and tell you about ICAP and what we're doing in order to support the countries where we work in the response to COVID-19. So I think importantly, our mission and our vision is really all about how do we ensure the wellness of families and communities by focusing on strengthening health systems. And obviously strengthening health systems is always of great importance, but I think COVID-19 offers a great opportunity for us to further invest in strengthening the health systems. And we realize our mission through 4 pillars. One is through education and training, research, service, as well as impact assessments and evaluations. So our support in sub-Saharan Africa, in particular in dark blue here are the countries where we work in sub-Saharan Africa, and this again shows the impact of COVID-19, has been largely through supporting health systems and the health system building blocks, whether it be through training of the workforce, developing new models of care, outreach into communities, strengthening laboratories and laboratory specimen transport system, collection of data, and so on and so forth. So all our investments has really been in terms of supporting the countries themselves and the ministries of health themselves to be able to achieve the goals and aspirations that they have. And in Africa, and thinking about the infrastructure that has been built over the last decade and a half, based on global investments, as well as the countries themselves and their own investments. There have been remarkable successes, and this is just one example in terms of the increase in the number of people living with HIV who are receiving HIV treatment. When I first started working in Africa in 2002, there were literally maybe 10,000 people in the whole sub-Saharan Africa who were accessing treatment. Now, if you look over time, in low and middle income countries, we've reached almost 25 million people are accessing treatment, and the world is set is moving along to actually achieving the 2020 end of this year target of having 30 million people on treatment. In Africa also, there's been remarkable advances by investments in other parts of the health system as well, like in maternal mortality. It decreased by 38% between 2000 and 2017. Of course, remains high in many countries, as you can see here in this map from 2017 of sub-Saharan Africa, but nonetheless enormous progress. Similarly, under 5 childhood mortality over the years, you can see here enhancements from going from the darkest orange, which is the highest rate, to lighter yellow and even purple, which means really achieve a very low under 5 mortality. So there's been enormous progress and infrastructure that has been built over those years. And I think that this existing infrastructure and resources, again, has the potential to really assist in this moment of crisis with this new threat. So for example, PEPFAR, the President's Emergency Plan for AIDS Release, that has done a lot of investments with the Global Fund in Africa, has supported, for example, that healthcare workers who are trained for HIV-related work, they're now moving to providing screening for COVID-19 in communities where they actually work. Again, the lessons learned on test and treat, the rapid, aggressive testing and screening and so on that has been established through the HIV response is very relevant to COVID response. Repurposing TB, Ebola protocols, isolation units, and control measures is also being done. Utilizing existing surveillance systems are very important, and now we're adding, and others are adding modules to collect data on COVID-19. incorporating COVID-19 programming into existing HIV tele-mentoring platforms that we and others are utilizing. And then utilizing the research infrastructure that's been established over the past 2 decades to conduct COVID-related research as well. And we and others have also tried to help as much as possible in this response. You can see in this slide, this has been through purchasing of personal protection equipment and medical equipment and supplies, establishing COVID-related treatment centers in support of the ministry, supporting task forces and the response units as well. Supporting the national COVID-19 surveillance system is very important, and again, building on work that we and others have done to establish a strong surveillance system. Helping to establish fever clinics and health brigades in several countries. And very importantly, of course, the healthcare worker training, which is very vital in the response and the management of COVID-19. And these are just some images of some of the work that's been done by setting in place hand washing stations, as well as screening activities, as well as, of course, going out into the community to track cases and contacts. So in conclusion, we're all aware that the story continues. The pandemic is not done, and it continues to grow and evolve, and we're learning as we're going. We're learning from other people's experiences. Taiwan and many other countries have offered enormous lessons to all of us as we tackle our own epidemic, and we're hoping that we can share our experiences with other countries that are coming behind, like, for example, African countries and some countries in South America, for example. Most African countries have thus far reported cases of COVID-19. The vast majority have, with maybe one country now that hasn't reported cases, Lesotho, I believe. The coordinated efforts across African countries is very important, is crucial for continent-wide response and mitigation. The borders, many of these countries, the borders are not they're only borders on a map. They're lines on a map. They're communities that live and mingle across countries, and people and families that have members across borders with other countries. So it's really important to have a coordinated response. Existing infrastructure, I think, position African countries to respond to COVID-19 with continued support, of course, must continue to get support from wealthier countries, highly resourced countries. I think it's also critically important to carefully monitor what's happening while we're putting in place all of these mitigation and containment measures. And I think that because we have to be cautious that there's no resurgence of cases after control. And finally, I think the response to COVID-19 should be vigorous. That's very important. It's an epidemic, but never at the cost of the need to pay attention and maintain attention to the other health priorities. And I leave you with the message that, as we all know, epidemics know no borders, and we have to care as much about our own communities, our own country, as we care about other countries around the world. Thank you.
Thank you, Dr. Sadar. And from there, we move quickly to the Indian subcontinent. Our next speaker, Dr. Rakesh Kumar, is the Chief Advisor of the United Nations Development Programme in India, where he leads policy support to the Government of India and state governments on sustainable development and builds effective cooperation and partnerships within United Nations agencies in India. Dr. Kumar has more than 27 years of experience in designing policies and implementing large public health programs, including programs in reproductive, maternal and child health, adolescent health, vaccines, non-communicable diseases, and he also led state and national level implementation and research portfolios at various government ministries and UN agencies in India. Dr. Kumar, without further delay, I invite you to tell us about the situation as you see it in India. You are probably very equipped to inform us and educate us.
So thank you, and greetings from India to all of you. Ayman, I was just trying to, listen very carefully to Dean Chan and then Professor Rafa. And I think India's story is no different. I would say it's a hybrid of both. And I say so because, you know, if you look at the India story, I run through, you know, I have some slides with me, so I'll try to run through those slides. So we all know that Wuhan city in Hubei province of China, they reported 44 cases of pneumonia. That was on 31st of December 2019. And obviously everybody knows now that, you know, this virus was a bit different from that of SARS or MERS or avian flu and all. On 30th of January, that WHO declared this as an emergency and public health emergency. On 11th March, finally it was declared as a pandemic. The first case for India witnessed was on 30th of January, the day when it was declared as a sort of public health emergency. If you look at the data as of today, you know, we have close to more than 35,000 coronavirus cases. Like I said, we had our first case on 30th of January. We have lost about more than 1,100 lives in the country, and more than 9,000 they have really recovered so far. So I would like to say that I think so far we have been able to do, you know, much better in terms of, you know, containing this virus. But if you look at the global data, as Professor Gopal mentioned, you look at, you know, look at in terms of numbers, you know, 3.2 million cases, you know, it's close to 10% of the positivity, more than 32 million people have been tested, you know, for corona. But look at the mortality, obviously US, you know, leads the tally, you know, with close to 35% plus, you know, the total mortality. Europe is put together is more than 1 lakh, more than 100,000, you know, deaths across the world. So I think the numbers are really very high, and especially in Europe and US put together is quite high. When we look at, you know, the COVID sort of, you know, numbers and total deaths, you know, as I mentioned, is the state I've already, I think I will cover. Now, if you look at the doubling of deaths, you know, across the world, then obviously, if you compare India with other countries like US and European countries, the doubling of deaths has been quite fast, you know, in other countries. But India's doubling, you know, look at up to 20 days of the virus being in position, the doubling rate was close to, of the deaths was close to 3 days. Then finally, it's now close to, it's rather more than 5 days. Doubling rate, and now we started bending the curve, you know. But if you look at other countries, then certainly I think that that number is still, you know, on the rise. Now, if you look at the India's response, I would like to just mention that, you know, India decided that it was a sort of, you know, scenario-based integrated approach. For example, we had 5 scenarios, you know, created. First was the travel-related case reported in India. That is the first scenario. Then we have total transmission of local transmission of COVID-19. That's the second scenario. Then if suppose we have large outbreaks and unable to containment, then the third scenario. Fourth is widespread in the community. And then finally, you know, a lot of it's a widespread. So I think these were the 4 scenarios, and we had a very integrated kind of strategy put in place. So I divided this into 2 parts. First, the primary. So I think the purpose was, I would like to just mention that India focused, I think, primarily on the prevention. And when I say so, I would say there were 3 cardinal principles. The first was, you know, the book which India followed. The first was that how best we can break or stop the chain of the transmission. I think that was the first thing. And obviously, you know, social distancing kind of, you know, restrictions put in place. You know, identifying the cases, quarantining them, you know, at the facilities or at home. But finally, the lockdown was there. So I think the prevention part, the first part was that how best we can stop the chain of transmission. The second important component here I would like to mention is about a very single, simple, and sort of honest communication, you know, which was open to the public. The message, right, you know, coming from the Honorable Prime Minister down the line. So there was a single messaging. So there was no communication gap, or there was no confusion. So any message emanating, let us from the national government, it was going down the line. And third, of course, if any case was there, then certainly obviously the treatment part. So I would say we focus more on the prevention and prevention and prevention. If you look at the management structure, we have a 3-tiered plan put in place. That we have union government. So obviously, the coordination was ensured among all the different ministries, which were responsible for mitigating this COVID. The second important, level is the state governments or the provinces. We have 37 states and provinces across the country. But I would like to mention here is the district, which is, if you look at the population of a district in India, it's close to 1.5 million to, let us say, 3 million times. So this is the size of the districts, so population is quite large. I would say that the main focus of, action was at the district levels. We call it the 3-tier. We had, if you look at the secondary arrangement, that it was a multi-level actions. For example, Government of India put in, a lot of legal framework. For example, we have something called a Disaster Management Act, which was of 2005, through which, Government of India empowered Ministry of Health, to take any decisions what they wanted to take. Similarly, they also, empower the district authorities at the district level in the state governments. Similarly, we have another act called as Epidemic Act of 1897, which was enacted, in the times of the bubonic plague when India, faced this particular problem. So, and this particular act also, we made a couple of amendments, and Government of India brought in ordinance. In the sense, when the doctors and the paramedical staff and the healthcare workers in the front line, they were started, getting kind of backlash from the public. Then obviously, then government made amendments to the act, and there was a severe punishment, which was, a rigorous imprisonment for up to 7 years of this thing, and recovery of the losses also in case, people, put the government assets or public assets or the private assets to loss. Then, IPC, we have Indian Penal Code of 270, article. Again, it empowers, it's basically nobody can really take, other person's life at risk. So anybody's, taking that. So this was also, put in place. Then CRPC 144, it means, that at one particular point of time, not more than 5 people can, travel together or come together. So this was the legal framework, but look at the institutional mechanism. I said the union ministries and the state governments and the district authority, they worked in tandem. And I would say there was a single line of communication. In my experience, in the last 27 years, I've never seen such a kind of arrangement where there was a single strong line of communication and there was a strong coherence. India is a multi-party, governance, in different states. But I think in this period, in COVID period, everybody was standing, as one single entity to fight this particular virus. Then laboratory support, again, that was the third particular intervention where the designated labs, we used to have just 75 when we started with this issue. Currently, the number of labs have been increased to close to 400. I think that is a tremendous thing which India country has done. Because you always know that unless you see the virus or unless you see the enemy, you can't fight. So the first and the foremost thing that we need to go for detection of the virus, of testing and testing and testing. So India's testing was, I would say, very poor in the sense that initially when we started, on 23rd of March, it was close to 14,000, but now it's close to 600,000. I think we have tremendously increased the laboratory testing. Obviously, hospital support. So we divided the hospitals at 3 levels: the primary level, second level, third level. I think I have next slide to discuss about it. The non-pharmaceutical interventions were put in place, very strictly. For example, social distancing or quarantine and isolation, and another, other public health measures. Then material logistics was very important because, there was a shortage of ventilators. We're talking about masks and PPE. So India now, focus more on in-house, production of these things. So Make in India initiative was put in place, I would say tremendously. So now we have in-house production of PPE, ventilators and masks. We also, guidelines were issued for stay arrangements of the field staff, biomedical waste management was also, a statement. Risk communication, again, I think one of the presentations which I have from Professor Baba, it talks about the risk communication. I think this was absolutely important and cardinal for us. So the material was centrally developed, and finally it was, translated into local languages, and it was circulated through the mass media, the mid-media, interpersonal communications. So again, the messaging was very strong, simple, straight, and honest. Information management at the district level, state level was ensured so that any information, so I would like to say the control rooms were established and the kind of BPO centers were established, and the information flow was so high that nothing was really lacking. And obviously important component is capacity building of the doctors, paramedical staff. So I think we also took a note of this. And I think everything, when we look at, I'll come to this particular slide, it talks about, data-driven sort of policies and actions, On 17th of January, we started the thermal screening of incoming international passengers. I think the first step to safety. Then on 5th of February, we started the travel restrictions, from COVID-19. I think there were 17 countries. Then finally, there was a local curfew. That was a curfew for one day on 23rd of March was imposed in the country. I think India wanted to experiment that how people behave, for this kind of lockdown for a day. Then on 25th of March, then finally we had a lockdown across the country, which was extended on 14th of March. So till now, the country is under the lockdown, and there's likely possibility that we'll have lockdown for another 2 weeks. I think they're soon going to decide. So this lockdown has really done wonders for the country in terms of look at the transmission and cutting down the transmission, not only cutting down the transmission, but I think important point is that it gave us time, it allowed us to prepare ourselves, for any eventuality in the future, whether we are talking about the logistics, supply chains, or whether we are talking about the hospital preparedness, anything and everything we talk, I think this 1 month, 40 days time has given India, to prepare for the worst situations. So when you look at the health facilities and healthcare strengthening, that 3-layered system was put in place. We have COVID care centers at the local level. Even the makeshift facilities were created, like hotels and hostels were created, schools as quarantine facilities. The second tier is called as dedicated COVID health center. So where the oxygen facilities are available, we have a dedicated basic life support ambulances available, so that if in case the patient develops complications, he or she can be shifted to a higher facility. And then we have dedicated COVID hospitals. We have facilities like ventilators and ICU facilities out there. Private hospitals have also been designated as COVID centers or high-end centers to handle the complicated cases are close to 10% or so. We, as I said, we ramped up our testing and surveillance. I think that is most critical. So if you look at the data in terms of surveillance, I think next slide speaks about that. But as I mentioned, from 14,000 tests on 23rd March, we are now increased to close to 19,000. So each day now our testing is close to 60,000 per day, and we are likely to touch it close to 100,000 in next, maybe a week or so. Look at the number of cases, as I said, it's more than 35,000, but the people who have been kept under observation and, after close surveillance is close to, 1 million. Now, what we did that we divided our, districts. As a total number of districts is 733 in the country. So we divided, the districts into 3 zones. The first zone is called as red zone or red district. The second is orange, and the third is green. So green is close to 319, which means there are no active cases of COVID-19. So I think that is something which is a good relief for us. Districts with very few cases are called as orange category, and district, when you call that red districts or red zones, then the number of cases of the classification, the cases, active cases are more. This is how we have classified the districts. For example, in the country, the total number of districts which are putting together more than 80%, they have been, earmarked as red zone districts. The second categorization is that 80% of the total number of cases within the state, in the districts which are containing this number of virus or cases. So this is the second category. And third, if the doubling rate of COVID cases is less than 4 days. So these are the 3 criteria which is taken into consideration to decide a district whether it is in a red zone or not. And again, today the government has taken a decision which says that the red districts doesn't mean that only the district. No, this could be a red zone. Red zone means it could be a street, it could be a village, it could be a municipal corporation, a bigger city, smaller city. But ultimately, the purpose is that we have to bring in the kind of containment. So as a result of lockdown, Dean, I like to mention that number of deaths obviously have really, this is an old data of 25th April, but I just want to show the result of lockdown. Certainly the number of cases have really come down. The recovery rate is faster and the number of deaths are also on the lower side. Our doubling rate is again, it's just close to 10 days, or rather today it was found to be 11 days. So we are hoping, and the decline has already started. So we are hoping that the number of cases, they don't really increase, based on the growth rate, based on the doubling rate. There's, a couple of best practices I would like to mention. When we talk about the Kerala model, I don't know, you must have heard about Kerala. Kerala is one of our best states in terms of health system. The first case was, detected in a district called Kasaragod. The first case was detected on 3rd of February. He was a student who came from Wuhan city. And they were so, because of their best sort of experience, the Nipah virus, we had in 2018. So they had a good surveillance system put in place. So I think one strategy which they showed rather to the country also was that they went out for aggressive testing, then containment. They imposed 144, sort of CRPC in the district. And then tracking of the contacts was again done in a very aggressive manner. They started with the welfare activities like distribution of ration and food material, and rather people were allowed, whether they're rich and poor. They said, okay, we'll ensure that the food supply is made available at home itself. They established about 200 ICUs, in the district. So health systems was already strengthened, put in place. In total, they received about 169 cases out of this 123 cases have recovered, and there was no death. So I would like to just mention, so this model was then finally adopted by the country, and it is being replicated across many states across the country. Chhattisgarh is one state which brought in this, the model of coloring. We're talking about red, green, and yellow. We have received, global acknowledgments, although it is too early with the talk about the Oxford University, with the research findings, based on the data from 73 countries. Then the regional, our office of WHO has really commended our work, and obviously the DG WHO. When you look at the challenges, and I think this is my second last slide, and I think I'll be quick and fast on this. I think challenges is that we need to, have maximum amount of testing, because as I said, unless you see the enemy, that is the virus, you won't be able to fight. So we need to really ramp up our testing. We need to ensure that we trace the contacts, we isolate the patients, and implement the COVID care plans. It's a huge challenge. Health systems in India, India has really invested quite a lot in health system, but still, they're quite fragile, and certainly I can easily make out and mention with confidence, especially in more part of the country. So because of the fragile health system, I think India can't afford to have, those kind of complicated cases across the country. We look at the non-COVID patients, then I think the care is suffering, it's neglected. I think somewhere we are missing the bus, because the whole system is focusing on COVID. What happened to non-COVID cases, whether they are the immunocompromised cancer patients or NCDs, or even the children. Look at the fear psychosis among the COVID patients and healthcare providers. I think this is absolutely very critical for the country. One patient or one doctor getting a sort of infection, it really impacting adversely on the frontline workers and the doctors itself. So I think we need to put in place some systems where this is some sort of psycho treatment, or a sort of psycho support can be provided to these patients and the doctors. Look at the vaccination program in the country. I think Professor Wafa mentioned about this. It is really suffering. Who knows that tomorrow, suppose we have a measles outbreak, it can kill more people, it can kill more children. And measles is more infectious than the COVID. So I think, and especially, other vaccines also, it's not only measles, but look at the pentavalent vaccine, look at any vaccine for that matter. So I think we are going to add to the problem in case we really don't really, tackle it quickly. Look at the RC's active reproductive maternal and newborn child healthcare. Again, they have really, they are in shambles. So I think, and this all put together can really escalate our maternal and child mortality. Simply, again, look at those chronic care patients, NCTs, again, it can take more lives. Management of economy is very important, especially the migrant labor. And we have, more than 400 million people in informal sector. When we put the lockdown, the country was put on the lockdown, then certainly I think so many people, they migrated out and were. This is my last slide. So in conclusion, I try to say that unlike developed nations, I think what India followed was more of prevention and preventive steps. Social distancing in future, whether you're talking about the uniform use of masks or hand washing, is going to be a new norm in the country. We need to ramp up our testing and health systems for sure. We need to train our paramedical staff and staff nurses, doctors in COVID-related management, because that's absolutely important. Drugs and vaccines, obviously they are in the research phase, but we never know. I mean, look at HIV. I was talking to somebody, 35 years, and we don't have a vaccine even till date. So we don't know, but we are keeping our fingers crossed that we have a vaccine soon, because that seems to be, that is the only solution. Use of technology, India is using technology quite a lot. I want to really, focus more on this. Lockdown, as I said, we have India halting the transmission of the health systems, and it has really tremendously helped. I like to end by saying that disease dynamics are no different for India. We're talking about COVID. Therefore, India should be prepared for the worst. So I'll stop short here and be happy to take any questions further. So thank you for this opportunity. Over.
Thank you very much, Dr. Kumar. And in the interest of time, I will move to our final speaker, our Senior Associate Dean for Student and Academic Affairs, and an expert in population informatics, which he has applied towards countries around the world. And I hope that we have given him enough time to give us some of his recent activities in the domain of COVID-19. Ashish, without further delay, we are excited to listen to you. Unmute, please.
Oh, yeah. Thank you so much, Dean Ayman, and I appreciate this opportunity. And I'll be just pretty quick on this. Okay. So I hope everyone can see my screen. So I'll begin with the building upon what my esteemed other colleagues have already illustrated about COVID-19. And I'll take a little bit of a different approach into this presentation about what is the importance of data, what is the importance of informatics, and how do we need to integrate both of them to come up with some data-driven policy making. So amidst all these challenges and uncertain times, I think we came up our kind of a conceptualization of this idea of a rapid tracker, which could be a global policy informatics platform to track COVID-19. The reason and the need for what this is, some of my talking points for this is, what are some of the data challenges which are related to COVID-19? What is the role of dashboards? And I think I heard in all of the presentations made earlier, the role of information technology, what it can do to aid decision making for the various policymakers. Third, I'll just briefly introduce what we are doing in terms of global policy informatics platform and how this is actually taking the data from such wide variety of sources across global countries and bringing them all together to make some kind of a meaningful insights. And lastly, this is a work in progress as we move along. The biggest challenge, how wealth of COVID-19 data can be used by policymakers to inform evidence-based decision-making. Now, if you take an example, everybody is saying we are looking at these trends, the numbers are increasing, the cases are increasing, but at the end of the day, we need to integrate this data into decision-making. And at what point, either our policy actions are working or they are not working. And so this is a big challenge because of so much information which is coming out. Big challenge, another aspect, the volume of data. That is a huge volume of data is coming out so rapidly, almost every single day, every single moment. The variety of data. So there are different forms of data. So you have social media, you have audio, text, interactive formats, you can say contributing articles, all kind of data sets are coming. Third is the velocity, which means the speed with which the data is getting generated. Lastly, which is very, very important, is now the veracity of the data, which means the uncertainty of the data. So you might be seeing right now that there are many countries who actually have started to update their numbers. So people who have been trying to build model using some of the existing data, there could be some kind of a challenge because new numbers are coming in, new data is coming in, and the numbers get updated. This could have a direct impact on some of the policy making. Now, with all these kind of data-rich environment, what we are facing is with too much information, too much relevant information, and too quick. And it is very difficult to distinguish which information is reliable and helpful. So this is the current data-rich environment and a data-rich society where we are living in. The most important aspect which becomes is, where is the value of the data and what value we need to derive from it, which means what is meaningful here. And how do we really translate this into something which can be used to guide decision making? So this is the current scenario of the data challenges, and this is the problem we wanted to address. As many of my colleagues already mentioned, that they have been using technology and dashboards to improve the user's ability to interpret and remember the relevant data. Some of the earliest dashboards which came was from the New York Times, which came up with representation of data across multiple formats. Now, obviously, it's not about just the aesthetics or how amazing graphs we can make. It has also to be interpreted by various stakeholders who may be statisticians, who may be system science modelers, who might be consumers, lay people. So how do we really communicate this into something which is informative in a way that somebody can also interpret it? The next was the WHO, which came up with the dashboard. Then we have obviously the Johns Hopkins one, which is now widely cited as another dashboard. We have NBC's dashboard, which is very popular right now. And lastly, we also have a health map. Of course, there are tons and tons of other dashboards. There was no specific reason for me to pick and choose, but these were some of the earlier dashboards which came up. And many of them started to create an open source opportunity for people to collaborate with common data storing platforms. Interestingly, all of these dashboards were focusing on not, I would say, data trends, but predominantly they were collating data on cases, recovered deaths, or new cases, or fatality, doubling of the cases. So it was very much focusing on the data aspect of it. However, there was a very, at a larger conference and by various researchers, policymakers, the important aspect was, how do we come and charter the territory out of this pandemic crisis? Is how do we effectively integrate data into this decision making? So obviously, you will have a lockdown, the cases might keep on going up. At some point, you might have to make a decision on how do you exit out. So how do we integrate this kind of policy making into the available data what we have? So what was our approach? And obviously, this is not necessarily the perfect approach, but this is how and what we are trying to attempt to achieve. There are two aspects. We are obviously living in a very data-rich environment. And secondly, there are policy. So the goal was, how do we really integrate this data and policy? And I intend to use a smart informatics framework. And the rationale for using this is that data could be just numbers. And it could be like, we have 2,000, 4,000, but there has to be some meaning to that. So that means, how do we translate this data-rich environment into something which is meaningful insights? And how do we use those meaningful insights to generate new knowledge through use of interactive visualizations? And this alone can be a cyclic approach, not a linear approach. Lastly, this conceptual model should help to facilitate data-driven, evidence-based policymaking. Another thing, this is a policy informatics tool. It helps to track geospatial spread of COVID-19 outbreak and policy actions. Largely, we are looking at how do we integrate data and policy to really look at what policies are working and what are not working. I will just quickly show here. We are tracking the policy actions globally. So in a way, we are creating a policy database. We are tracking the COVID-19 case burden all over the world. And we are looking both from the spatial as well as the temporal aspect of that. And the goal is to track critical insights which can help us to inform the various stakeholders to make informed decision making. Lastly, I will rush through this. I don't want to take too much of time, but I just wanted to show the highlight. We are able to drill down this comparative model of various countries. So somebody might say Taiwan is a model of success versus Singapore versus South Korea, but there are many underlying features which would be differences. Each country might have their own policy implications, and it is not easy to just translate them into a different country. So goal is, how do we really map this together? So just to give you an example, we are now looking at this last slide of the dashboard, for example, specifically focusing on that on March 30th, if there was a travel restriction in the US, in real time, we are starting to see how those numbers and the rate of change is happening along with the policy decisions. So the goal here is, if the policy actions are not working or something which is being missed out, can this help us to make informed decision early? So this is also helping both from the preparedness standpoint of view as well as from the monitoring and the management standpoint of view. Lastly, this is a work in progress. As I mentioned, it's a model of flexible approach. Our goal is to develop global policy database to track government response to COVID-19, and how can this be a decision aid tool for the various governments, policymakers, and researchers for informed policymaking. I would like to acknowledge our collaborators worldwide. And also, this is a platform, smartrapidtracker.org. I'm very proud to be a part of CUNY Graduate School of Public Health and Health Policy for giving this opportunity to put this platform out in our global collaboration. And I am also looking to encourage our students and our policymakers, researchers to contribute to this platform. And students are more than welcome to use this as an opportunity to conduct policy analysis, to do epidemiological data analysis, and also to think about how data and policy informatics all come together. Lastly, I know this is a challenge, but I always say obstruction is always an opportunity and innovation is struggle. Thank you so much. And sorry if I'm rushed through, but more than people can go through this website and see what we are coming up with our daily insights. And lastly, I want to thank Dean Ayman for giving this encouragement and motivation. And I want to thank all the folks, students who are contributing to making this platform a rich resource to helping us collectively address this public health crisis. Thank you very much.
Thank you, Ashish, so much. Thank you, Dr. Kumar. Thank you, Dean Tran, and thank you, Dr. Sadar. What a rich opportunity for us today to discuss the global perspective. At this point, I want to announce our last in this series of the COVID seminars next Friday, and we will hone back in on New York City, reviewing with you the results of the CUNY School of Public Health poll that we have conducted for the past 8 weeks. With me on the panel will be Dr. Vicky No, Dr. Nick Freudenberg, and Dr. Scott Ratson. I'm very grateful to all of you that have participated, and thank you so much for a wonderful and rich seminar today. Greatly appreciated. And thank you for our participants as well. Thank you.
Thank you.
Thank you.